Hi guys, welcome back to my channel Obgyn Made Easy. In today's video, we are going to discuss upper and lower urinary tract infections. A urinary tract infection is an infection in any part of the urinary system like the urethra or the bladder or the kidneys. Urinary tract infections comprise of upper urinary tract infections as well as lower urinary tract infections. For the upper urinary tract infections, you have pyelonephritis, which is infection and inflammation of the kidney. You have ureteritis, which is infection and inflammation of the ureter. In lower urinary tract infection, you have cystitis, which is infection and inflammation of the bladder. And then you have urethritis, which is infection and inflammation of the urethra. The incidence of urinary tract infections is about 1 to 3% of the pregnancies. And the etiology is multifactorial. It's more common in prime gravidas than multiparous women. And there's almost always a presence of asymptomatic bacteriuria. Asymptomatic bacteria is a condition in where there's bacteria in urine, but it does not cause symptoms of a urinary tract infection. But that asymptomatic bacteria, the bacteria in the urine, can cause a urinary tract infection. There might be previous history of a urinary tract infection, and immunosuppressive conditions like diabetes mellitus confers a risk for you to acquire a urinary tract infection. What are the predisposing factors in females that make them more likely to get a urinary tract infection than in males? They have a short urethra, which is about 4 centimeters. So this actually makes it easy for bacteria to ascend from the urethra into the bladder. The close distance of the external urethral opening to the vulva, vagina, and anus. So you remember that the urethra is very close to the vagina. So the bacteria in the vagina, the vulva, can easily get into the urethral opening. Sexual intercourse is also a predisposing factor because the male genital organ can easily introduce infection inside the vagina. Catheterization is a predisposing factor in both males and females, but most likely in females because they have a short urethra. So it's easy to get infection inside the bladder. There's also special predisposing factors in pregnancy. There's dilatation and reduced peristalsis in the ureters due to increased progesterone levels. So remember that progesterone causes relaxation of the smooth muscles. So if the urine in the ureters just remains stagnant or remains static, bacterial multiplication can start, which can result into a urinary tract infection. Progesterone also causes relaxation of the vesicoureteric sphincters, which causes stasis of urine in the bladder. There is dextrorotation of the gravid uterus, which compresses on the right ureter. So what happens is when the uterus is growing and expanding, it rotates to the right and sits on the right ureter. So there's obstruction of urine outflow from the ureter going to the bladder. So this obstruction also causes hydronephrosis. So it's common for pregnant women to have right hydronephrosis because the urine starts building up in the kidneys. Hydronephrosis is simply fluid in the kidneys. And that obstruction also causes stasis of urine, which causes multiplication of bacteria, which causes a urinary tract infection. So as you can see in the diagram here, there's a gravid uterus here sitting on the right ureter, which causes compression on the right ureter and results in dilatation of the ureter. So you find that instead of urine going this side, it's going back to the right kidney. So there's no flow of urine here. So there's stasis of urine, which causes multiplication of the bacteria. And that same bacteria is going into the right kidney instead of going towards the bladder. And this is the reason why pyelonephritis is more common on the right kidney than on the left kidney in a pregnant woman. Between the bladder and the ureter, you have a vesicoureteric sphincter. What this sphincter does is when you're about to micturate, when you're about to urinate, is that it closes and helps with contraction of the bladder so that urine actually comes out of the bladder and goes into the urethra. But in this case, because of progesterone, it causes relaxation of the vesicoureteric sphincter. So this sphincter remains open here, and you find that instead of it closing during contraction, it remains open. So some of the urine goes back into the ureters. So there's reflux of bacteria back into the kidneys. And the urine that remains in the bladder, because it's not going anywhere, it's not going out of the urethra, remains stagnant. So there's multiplication of bacteria, which can cause a urinary tract infection. The common organisms that cause urinary tract infections are E. coli, which is the most common organism, Klebsiella pneumoniae, Enterobacter, Proteus, Pseudomonas, and Staphylococcus aureus. Remember that these organisms come mostly from the vulva, vagina, and the anus. So in a woman, it's very important when wiping, when after urination or defecation, to wipe from front towards backwards. Otherwise, if you wipe from back to front, you're going to carry the organisms from the back to the vagina and the vulva. So we'll briefly talk about the lower urinary tract infections and the upper urinary tract infections. For the lower urinary tract infections, you have urethritis. So it's very rare for urethritis and cystitis to occur alone. They usually occur together. So in urethritis alone, you have symptoms of dysuria, frequency, urgency, and sometimes you get a urethral discharge or urethral discharge of pus. Isolated urethritis alone is commonly caused by a sexually transmitted infection like Neisseria gonorrhea, chlamydia, or trichomonas. So you treat urethritis with azithromycin or erythromycin or ceftriaxone or cefixime. Cystitis is when the infection is limited to the bladder, and it's the most common of the urinary tract infections. Symptoms include dysuria, painful urination, frequency, urgency, and on examination there will be suprapubic tenderness, because that is where the bladder is anatomically located. So you do a urinalysis and a urine microscopy culture for sensitivity before you start giving antibiotics. You treat with nitrofurantoin or augmentin or cefalexin. Upper urinary tract infections include ureteritis and pyelonephritis. In ureteritis, it's very difficult to make a diagnosis on its own. It usually occurs with pyelonephritis, so you treat it as in pyelonephritis. In fact, clinically, you won't find a patient and say this is ureteritis. They'll most likely come with pyelonephritis. Pyelonephritis is infection of the renal pelvis and parenchyma. This is the kidney. It's common in the right kidney because we said the extrorotation of the graviduous stress occurs on the right side of the body, which compresses on the right ureter and causes right hydronephrosis. But it doesn't mean it can't occur in the left kidney. It can occur in both kidneys. It usually occurs after 16 weeks of gestation age. So in summary, urinary tract infections start from the lower urinary tract infection, the urethra, the bladder, then ascend into the kidneys. So if the infection is not controlled at bladder level or at the urethra level, it can complicate into pyelonephritis, and that becomes a very serious condition. So I'm going to focus a bit more on pyelonephritis right now. Clinical features of pyelonephritis. So the patient will come in with complaints of fever, chills and rigors, nausea and vomiting, backache. Backache occurs because remember that the kidney is a retroperitoneal organ. Abdominal side pains, low abdominal pain. It can actually mimic labor pains. There might be difficulties in breathing due to pulmonary edema and endotoxic shock. This is when the pyelonephritis has complicated into overwhelming sepsis. When you examine the patient will look toxically ill, might be dyspneic, febrile or cold to touch, suprapubic tenderness because that's where the bladder is, and renal angle tenderness because that's where the kidneys are. Investigations to do in pyelonephritis, you do a urinalysis. In urinalysis, you see there's leukocytes, protein, or even nitrites. You do a urine microscopy culture and sensitivity to see which bacteria is causing the urinary tract infection. You do a full blood count and differential count. You might find that there's leukocytosis or thrombocytosis or thrombocytopenia. You do an RDT for malaria and malaria parasite slide. Remember that malaria can mimic pyelonephritis, so it's one of the differentials for pyelonephritis. You do urea and creatinine to see how the kidney is functioning, because pyelonephritis involves the kidney and it causes damage to the kidney. You can also do a blood culture to see which organism is growing in the blood. Differential diagnosis of pyelonephritis. Remember that pyelonephritis can mimic labor pains, and also pyelonephritis can cause an acute abdomen. And abruptio placenta can also present as an acute abdomen. The other differentials are choriamnitis. Choriamnitis is inflammation and infection of the amniotic sac, the chorion and the amnion. The other differential is red degeneration of fibroid. When there's red degeneration of fibroid, it can mimic an acute abdominal pain. The other differential diagnosis based on temperature, fever, nausea, vomiting is malaria. Acute appendicitis can cause acute abdominal pain. Acute cholecystitis can cause acute abdominal pain. Complications of pyelonephritis. For the fetal complications, you can have a miscarriage, preterm labor, low birth weight, intrauterine fetal demise, and choriamnitis. Remember that pyelonephritis is a serious condition and can result into septicemia as well as sepsis. So if you have sepsis, this results in these fetal complications. For the maternal complications, you can have pulmonary edema, anemia, and septic shock. This is because of sepsis. So if pyelonephritis results into a full-blown sepsis, it can be very overwhelming for the mother as well as the fetus. And because pyelonephritis affects the kidneys, you can have renal dysfunction. Management of pyelonephritis, you give a maintenance intravenous fluids. Remember that fluids help flush out and clean the kidneys. You give broad-spectrum antibiotics like ceftriaxone or benzopenicillin with gentamicin for at least 48 hours or until the patient is afebrile. Then you switch to oral antibiotics and you give for a total of 14 days. You adjust the antibiotics according to the culture report. Remember, you collected urine for microscopy culture and sensitivity, and if you also collected a blood culture, this will help you to adjust the antibiotics accordingly. You give acetaminophen for fever and pain. You repeat the urine culture after 2 weeks of antibiotics and then at each trimester. This is because urinary tract infections have a tendency to reoccur. If symptoms reoccur and urinalysis is positive for leukocytes and nitrates, repeat a urine culture and retreat the patient. Recurrency is common, so give prophylactic nitrofurantoin 100 mg once every day until after delivery. So this is how we manage a case of urinary tract infection and pyelonephritis. I just want to point out to say let's stop using amoxicillin to treat urinary tract infections in pregnancy, because amoxicillin use has been associated with recurrency of urinary tract infections. So let's use the antibiotics according to guidelines. So this comes to the end of our discussion on urinary tract infections and pyelonephritis. Please don't forget to subscribe to my channel for updates. Thank you.